All right, good morning. I'm Marvin Atkins. I'm a cardiac and vascular surgeon here at Houston Methodist. I'm going to talk to you guys about thoracic and thoraco-abdominal endovascular management. All right, so briefly in 15 minutes, going to be able to plow through thoracic and thoraco-abdominal aneurysms and their endovascular management. All right, so first of all, let's get some basic definitions out of the way, which I know may have not been covered in some of the other lectures that are kind of very important when we look at the literature, and especially as we start talking about thoraco-abdominal aneurysms, to make sure to be able to compare apples and apples to oranges and oranges. If we're not calling them what they truly are, then we're messing things up. So obviously we all know what an infrarenal AAA is. A juxtarenal means that you clamp above the renals but you sew below. A suprarenal or a pararenal aneurysm means at least one of the renal arteries needs to be involved in the aneurysm. Or one of the visceral vessels. Type 4 thoraco-abdominal aneurysm is the total abdominal aortic aneurysm, which means all of the visceral vessels are involved in the aneurysm, but it starts below the diaphragm. A type 3 means it's somewhere around T6 where it starts in the mid-descending thoracic aorta and goes down below the renals. The type 2 is the most extensive thoraco-abdominal aortic aneurysm from the subclavian artery down to the renals. Type 1, again from the subclavian artery to above the renals. There's a type 5 proposition by the group at UT across the street from Dr. Safi, basically from the lower descending thoracic aorta but above the renals. You can have a mega aorta. I've seen that before, where essentially the ascending arch and the entire descending aorta is aneurysmal, and those become very difficult in your management of what you're going to fix first. And then if we're talking about a descending thoracic aorta, distal to the left subclavian artery, above the diaphragm. So that's just the basic nomenclature. Again, here's the Crawford classification. Essentially types 1, 2, and 5 are distal extensions of thoracic aneurysms. Type 3 and 4 are cephalid extensions of abdominal aneurysms. The vast majority of aneurysms are, again, in the infrarenal aorta. 12% are in the descending thoracic aorta, 5.5% in the ascending, 2.5% in the thoraco-abdominal segment. So they're unusual aneurysms, infrequent, and they're difficult and sometimes hard to manage. 6 to 13% of thoraco-abdominal aneurysm patients will have an ascending aneurysm. So all these patients get imaging head to toe, so you're going to take a look at the ascending as well. It's rare for those to happen except in patients that have either a dissection or they have a connective tissue disorder. Of your patients with a thoracic aneurysm, 20 to 30% will have an infrarenal AAA, and the converse of that, of those that have an infrarenal AAA, 5 to 10% will have a thoracic aneurysm. So a lot of times you'll get sent maybe a patient that has a CAT scan of either the chest or the abdomen. Make sure you look at both. So what's the clinical presentation of these thoracic aneurysms and thoracos? So most of the time, the patients are asymptomatic. This was an imaging study done for another reason, found to have that. They can, however, cause chest pain, mid-epigastric pain. If it's stretching the hiatus, patients will describe kind of, either mid-epigastric or back, kind of mimicking pancreatitis type of pain. They can present with hoarseness. If it's a large aneurysm especially, remember your left recurrent laryngeal nerve swings around the distal arch there, and it can stretch on your recurrent laryngeal nerve, and they can become hoarse. They can have dysphagia. If it compresses the lungs, they can have chronic cough. So what's the natural history of these? So this is older studies from the 60s, 70s, 80s. It's dismal. These patients, if you follow them out long enough, they don't survive, they rupture. Again, a lot of this was before good medical management, dual impulse therapy, beta blockers, statins, all that type of stuff. But in general, these patients are going to die of their thoracic or thoraco-abdominal aneurysms. So the rupture risk is not as well defined as it is for abdominal aortic aneurysms. In general, it's thought for both thoracic and thoraco-abdominal aneurysms that the rupture risk is negligible, below 5 centimeters, probably equivalent to surgical mortality between 5 and 6. We typically talk about repairing descending thoracic aneurysms when they're 5.5 centimeters or thoracos when they're 6 or greater. Again, that all totally depends upon the patient. You have a patient with Marfan's, dissection, your threshold for fixing those goes lower. If you have a patient that's very sick, a lot of comorbidities, older, pulmonary disease, renal disease, your threshold for fixing that goes higher. I've had patients with 7 centimeter thoracos that I've watched because they're just too sick to do anything. So our society guidelines and others basically, in general, for a descending thoracic aorta, the number is 5.5 centimeters. You can have saccular aneurysms, postoperative pseudoaneurysms, co-arc repairs, stuff like that. The more focal aneurysms, sometimes you'll fix those as well. And stent grafting, for the most part in these patients, if they have adequate proximal and distal landing zones and access, that's the way to go. If we look at the open repair, you can look at all the studies published here in Houston across the street. They'll talk about less than 5% mortality, less than 5% stroke rate, less than 5% paraplegia. If you look at real-world data, the one on the left there is California, and then the other one is from the Michigan group, basically looking at elective intact thoraco-abdominal aneurysm repair in the United States. The mortality rate is truly between 20 and 30%, which, not too many people are going to sign up for an elective operation that has a 30% mortality rate. So, how all this got started, mainstream in the U.S. was back in May of 2005. The first thoracic stent graft that came out was the GoreTag device. Again, it decreased the mortality compared to open surgical controls from 6 down to 2%. The paraplegia rate was significantly less, and stroke rate was equivalent. So basically, when I see patients that I'm thinking about treating them with a TEVAR for a thoracic aneurysm, basically it's the rule of 5. So 5% mortality, 5% paraplegia, 5% stroke rate. So your PreCase planning for all of these thoracic endovascular repairs is very important. Once TEVAR came around, the number of treated thoracic aneurysms exponentially increased in the United States. There can be straightforward cases, there can be very difficult cases. It's all about the anatomy. You have to anticipate complications, access issues, whether they need to have a conduit. These devices have gotten smaller and smaller, which has allowed more patients to be treated. And we'll talk about a little bit about some of the risks of that. When they start making smaller devices, thinner devices that don't have the same radial strength, they've had some issues of devices collapsing and things like that. We see that in the abdominal devices as well. There is the risk of paraplegia, of course, that is increased in patients that have had prior aortic surgery. Their collateral supplies have been taken when they had other grafts or other AAA grafts placed. If they have subclavian involvement where you're going to have to cover the subclavian, that may increase your risk of paraplegia. If they have hypogastrics, also another important collateral, either disease or if you have to cover that for some reason with your sheath, all of that can increase your risk. I've had patients where they had one hypogastric that was out, and then the other one, if you went up that side, you would cover it for the majority of the procedure with that type of sheath. I would move that sheath over to the side where you already had the occluded hypogastric and allow flow to get down there. So there's a lot of little subtle nuances that you have to think about during the procedure beforehand to keep you out of trouble. And again, the critical area they talk about is kind of the T8 to T12 intercostal area. If you have to cover that area, your risk for spinal cord risk goes up. You need to have a lumbar drain in those patients. You need to keep their pressure up during the case, after deployment, and then in the ICU afterwards. So again, having a proper imaging system. Fortunately, these days, people have good hybrid suites. Before, people used to use C-arms and really deploying stuff in the dark, and it was crazy. And so a lot of that's gotten better. Again, preoperatively, if you can, for elective cases, the guidelines from SVS would be to revascularize the left subclavian artery beforehand or at the same setting. And then again, be aggressive about spinal drainage. Trauma patients, for the most part, obviously, you're not going to do that. Patients that have very small penetrating ulcers, focal little saccular aneurysms after a co-arc repair, something like that, you're covering a very short distance of the aorta, very proximally. You can probably get away without a lumbar drain. Otherwise, it's very difficult. You wake your patient up at the end of the case. They didn't have a lumbar drain. Now they have a neurodeficit. They're still heparinized. They're, had incisions in the groin. How are you going to get them bent over in the bed and have the anesthesia folks put a lumbar drain? It's possible, but all those types of things are much harder to do as an afterthought as the patient's not moving their legs afterwards. So, the risk of complications with spinal drainage is relatively low in centers that are used to doing it. In general, you probably need at least 2. Some of the devices, they recommend 2.5 centimeters of proximal and distal landing zone. If you don't have a good landing zone, make a good landing zone. and there's different ways you can think about that. The devices, depending upon whether it's some of the newer devices that are lower profile, in general you need about an 8 millimeter iliac. Know your device, know its limitations, know what the IFU requirements are, stay within that for thoracic disease, and you'll stay out of a lot of trouble. Iliac tortuosity, very tortuous iliacs. Sometimes the stiff wires alone from below will get you out of that. Sometimes you have to come and use a buddy wire from above, so come in through the brachial, left brachial down, snare it, bring it out, and then you've got body floss across, coming out of the arm and then out of the groin, and you can put a device over that much easier. Watch out for common femoral disease if you're trying to do these things. Percutaneous, of course. Be careful with that and make sure you check your pulses and all those good things like a good vascular surgeon should. In the older studies, especially when the devices were bigger, conduit use was very high. Now it's much lower as the devices have become much more flexible, lower profile. But don't be afraid, and somebody that has significant iliac calcium or stenosis to put a conduit either to the common iliac artery or to the aorta directly. In small patients for trauma, if the vessels just appear too small, I've made a small little laparotomy and just stuck the aorta directly like it was a vessel, and that's a good way to put in a TEVAR for trauma, especially if the abdomen's open for other injuries. And then know your anatomy regarding the carotids, the vertebrals, the circle of Willis, especially if you have to cover the subclavian, if there's a vertebral that comes directly off of the arch. Those types of things. So know the anatomy and stay out of trouble. Again, you can do these percutaneous, you can do it open. The axis is the most important thing. People have gotten away from these endoconduits of tight iliacs where you put a Viabond in there and crack and pave and basically controlled rupture the artery. And so be aggressive about putting conduits on if you need to. 3D imaging with centerline measurements are absolutely essential. Know your landing zones, know where you're going to put this graft in, and know your road to get there. I'm going to skip through some of this stuff. IVUS, I've found that very helpful in patients, not just in dissections, but also in elective aneurysms as well. It allows you to use much less contrast, especially if patients have renal insufficiency beforehand. You can leave an IVUS catheter up there and even get ready to deploy and mark where your vessels are, put your graft into position to deploy it. Again, helps out in dissections, helps out to look for any narrowings in the devices afterwards. The other thing it's useful for in the trauma patient population, which they didn't really talk about, is that a lot of these patients are hypotensive. They get their CT scan as they're hypoperfused. The aorta is not really dilated, and so you can actually undersize the device. So once they get resuscitated, they're doing better in the operating room when you've got them there now. Now the aorta is actually much larger than what it was when they were in the trauma bay and hypotensive, and so you can inadvertently put in too small of a device. And so in trauma patients, I would always, if we had time, run an IVUS catheter up there and confirm my measurements, and it definitely several times changed the device size that I was going to put in and put a larger device in, because obviously in trauma and dissections you're only supposed to oversize maybe 10%, so you really need to make sure you're putting the adequate device in. We all kind of know the steps of this stuff. For the most part, you don't balloon in dissections or trauma. The pre-curved Lunderquist is great, very stiff wire that allows you to get these devices in. Follow-up, the SVS just published last month or two some guidelines for follow-up imaging, and basically for TEVAR, it basically says the data is not great in terms of follow-up. You need to have a CT scan within 30 days of the procedure, and then if on that 30-day CT scan they have an endo leak, you probably ought to get another scan at 6 months. If they don't have an endo leak, you could probably get one at a year. In the absence of further data, they're continuing to suggest that we ought to get annual CT scans. Some people have moved to MRI. If you have other patients that may not follow with that, you can just get chest x-rays, multiple view chest x-rays, and see if the device has changed in configuration or location based upon the bony anatomy landmarks. There is going to be a risk that we're going to find out that continued yearly CT scans in young patient populations are probably not the best thing, especially if you're given contrast and the kidney effects that'll have down the road. Again, TEVAR pitfalls would be sizing errors. Basically, these cases are done before you ever get in the operating room. You need to have adequate lengths for seal zones, anticipate complications, great vessel involvement. Again, you can't cover the subclavian if they've had a previous coronary bypass with a lima graft. If they have a vert coming directly off the arch, theoretically you could look at the vert on the other side. You could transpose the vertebral to the carotid. That's an unusual operation. I think I've done that once. And then obviously if they have a dominant left vertebral coming off of that left subclavian, you don't want to cover your subclavian. Carotid subclavian bypasses in those patients beforehand versus transposition. I've found this carotid subclavian bypass to be much easier. It's just hard to transpose those vessels. If you have transverse arch involvement, you can, like I said, you can make a landing zone, so median sternotomy, and then bypass the innominate or the left common carotid. Or you can stay up in the neck and just do bypasses. The group at Duke has shown that if patients have a diseased ascending aorta and you're just putting a upside down bifurcated aorta femoral graft and deep branching the head vessels, that over time those patients are going to degenerate, get a pseudoaneurysm at your proximal anastomosis, reduce sternotomy, back in and fixing all that. So if you're going to put them through all that and they're healthy enough, go ahead and replace the ascending aorta, bypass those grafts, put good markers on there, create a good 3 centimeters or so landing zone, and then go ahead and do your TEVAR at the same time or afterwards. There's a lot of branch grafts that are coming down the road. The Cook branch device has been out there for years. There's a lot of stuff from Stéphane Holland in France. You know, really hasn't made it over the U.S. other than maybe the Cleveland Clinic and a small series. The Mona Lisa graft has been on and off of study stuff. It's not available. The TBE device, I've had some experience with that at Penn, and it was relatively easy to do. It's a retrograde branch, and hopefully that'll probably, I would suspect, be the one that comes to market first. The Bolton dual branch, which is you do a carotid subclavian bypass, and then one goes in the innominate, one goes in the carotid. That just started a trial in the United States about 3 months ago. I think there's been 3 cases or so that's done. And it's somewhat promising because it's an antegrade flow coming around. So that's the stuff coming along the horizon. In regards to the thoraco-abdominal segment, Cook has a device out there. Again, the Mona Lisa we just briefly talked about. People used to modify grafts, burn holes. I've done that a couple times. That's hard. People got away from that. The T branch is coming out there. It's in study in the United States. Again, 4 downgoing branches. The Gore Tambi device, a similar kind of concept, but by Gore. Medtronic has a device where they took a talent graft basically and just made a big 4-branch thing coming off that comes off high in the chest that comes down into your visceral vessels. So if you kind of look at the thing, it looks like an abdominal graft above, maybe an iliac branch thing below, and then this octopus thing coming out in the middle. Pat Kelly at where is he at? Sioux Falls, I think, is proposition that device came up with that. So there's a lot of stuff that's going to be coming down the road regarding thoracic and thoraco-abdominal aneurysms repaired from an endovascular means. I was recently at the AATS Aortic Symposium, and they had Caselli go up there and give his results of 3,600 open thoraco-abdominal aneurysms with 2 or 3% mortality, 2 or 3% paraplegia rate for all these patients. And then Gustavo Oderich from Mayo came up and presented his 400-patient endovascular series with essentially the same results. So I would suggest that not everybody can reproduce the results that Joe Caselli has, and I don't think everybody can reproduce the results that Gustavo has. So there'll be a lot of new stuff coming down the pipeline that's going to change the management of these aneurysms. Cool stuff. Thank you.